So this is the examination series by the Department of Medicine of the University of the West Indies, Mona, and these series of examinations are for the introduction to medical practice. I am Dr. Rosemary Wright-Pascoe, and I will be taking you through the examination, which is called the general examination. The first thing you need to do is to introduce yourself to the patient. I am Dr. Wright-Pascoe, and I'm going to be examining you today.
Right.
As you are speaking to the patient, you should be observing whether the patient is in cardiopulmonary distress or not, and by that we are looking and assessing his respiratory rate. You should also be at the same time observing the patient's response to you. Is the patient making eye contact with you? Is the patient interested in the surroundings? Or is the patient apathetic, not making eye contact with you, not interested in the surroundings? Is the patient more anxious than you would expect? Does the patient appear more elated than you would anticipate? Or does the patient appear depressed? The demeanor of the patient is very important as well. Lie down for me, please. As you ask the patient to lie down, you are observing the movement of the patient. If there are any abnormalities of movement, including tremor or any weakness of any part of the body, you must ask the patient to undress. You must expose the patient as much as possible. Please undress for me. And while the patient is undressing, again, you're looking to see whether they are able to hear your instructions and follow your instructions appropriately. Lie down for me, please. We're interested in the patient's age, whether the patient is young being less than age 35, whether the patient is middle-aged, age 35 to 65, 64.99, or whether the patient is elderly, over the age of 65, because, of course, different diseases cluster in different age groups. Interestingly, also, you are interested in whether the patient appear younger than their stated age, which is associated with some diseases, such as thyrotoxicosis and sickle cell disease, or whether the patient appears older than their age, which again implies the chronicity of diseases. So this is a young gentleman, and he's lying propped up in bed on one pillow. The position of the patient is important because some patients are unable to lie flat because they're in cardiopulmonary distress, and they may have what we call two-pillar orthopnea or three-pillar orthopnea. So the position of the patient is important. In addition, you want to know if the patient appears well or whether the patient is ill-looking. And you give degrees of illness, whether the patient is mildly ill-looking or severely ill-looking. So to summarize then, just by simply speaking to the patient and asking the patient to just undress and to lie in the bed, you're able to determine and get a lot of information from just these three maneuvers. We are now going to start the formal examination. So the examination starts at the face. And as we look at the face, we are interested in one, whether the patient has any obvious abnormalities of the eyes, such as proptosis, that is, which this patient has, or ptosis, which some patients may have, whether the patient has periorbital edema, which may suggest the presence of nephrotic syndrome or chronic kidney disease, whether the patient has a malar rash, which would suggest the presence of systemic lupus erythematosus, whether the features appear coarser than normal, which you may see in hypothyroidism, whether there are any abnormalities of the nose, which you may see in scleroderma, with resorption of the allinase, as well as thinning of the lips, or whether the lips appear exaggerated and the features are exaggerated with protrusion of the jaw, so-called prognathism, which you see in acromegaly. So just simply by looking at the patient, one may see many stigmata of many different diseases. One also is interested in the presence of hair on the face. This is a man, so hair on the face is appropriate at this age, but if this were a female, this would imply the presence of hirsutism, which would suggest that the patient has hyperandrogenism. Again, also, the presence of acne is important, and acne is an appropriate disorder in young and teenagers, but in the elderly and in the middle-aged patients, it may suggest the presence of hyperandrogenism. The hair is also important. Does the patient have alopecia? Alopecia is associated with certain diseases such as thyrotoxicosis, as well as male pattern baldness in the female, may suggest the presence of Cushing's syndrome. So, we are now going to do the formal examination, which is to examine the mucous membranes. We're now going to examine the mucous membranes for pallor, pinkness, as well as for hydration status. Look up by gently pulling down using the thumb of your fingers. You are able to expose the mucous membranes. The mucous membranes are pink and they are moist. You now want to examine the sclera. Look down. You give the patient an object to look at, and you ask them to look down and look at this object, and you expose the unexposed sclera, which is what you're interested in, and this patient, the sclera is anicteric. We're now going to examine the mouth. Open the mouth for me, please. Lift the tongue up. We are looking at the inferior surface of the tongue, looking at the blood vessels as it courses the inferior surface of the tongue, looking at the degree of pinkness or purpleness, whether the patient has central cyanosis or not. It is important that you observe the patient while the patient is undressed. But we must recognize the privacy of the patient, and so the pubic region should be covered as much as possible. As I've demonstrated here. So we are examining the oral cavity, and we need a tongue depressor. We will also require a flashlight. Open the mouth for me, please. Lift up the tongue. We're looking for the degree of cyanosis, if any is present, and there's none present here. But we're now going to formally examine the oral cavity. We're looking at the health of the teeth. Patients who have carious teeth may have aspiration of the organisms in the mouth and may develop lung abscesses. Open the mouth for me wider. We're looking to see if there is any evidence of candidiasis. Oral candidiasis is relatively common in the HIV population, and oral candidiasis will present as white plaques that are adherent to the mucosa, and which, in your attempts to remove these plaques, may result in bleeding. We also want to have a look, open the mouth for me please, at the tongue itself. The size of the tongue is important. If the patient has macroglossia, then this patient might have hypothyroidism, for instance, or amyloidosis. Stick out your tongue for me, please. Stick out the tongue. Okay, so we're looking at the size of the tongue. Open the mouth as wide as you can. We are now going to check the patient's gag reflex. Say ah. Say ah. Okay. And we're looking for the movement of the posterior pharyngeal wall and the uvula, whether it moves appropriately and whether the patient has a gag. And as you can see, by pushing the tongue depressor down onto the posterior pharyngeal wall, the patient will gag and the pharyngeal wall will move upwards. This is also can be assessed formally when one is doing the examination of the cranial nerves. We're now going to check for lymphadenopathy. We start to check for lymphadenopathy by looking at the submental groups, the juxtajugular groups, the preauricular group, the postauricular group, the posterior occipital group, then the posterior cervical group, and we end with the anterior cervical group. We follow that up with the subclavicular group and then the scaly nodes. In examining the lymphatic system of the head, one is concerned with the size of the lymph nodes, whether the lymph nodes are mobile or not, whether they're hard, firm, or soft, whether they're tender or not. We are now going to be using our 4 fingers here. Palpation is a rounded movement, moving from group to group We're now at the juxtajugular group, the pre-auricular group, the post-auricular group, lifting up the head, at the occipital ridge, the occipital group, going down, the posterior cervical group, palpating the anterior cervical group one at a time, because you may palpate the carotid arteries, and palpation of the carotid arteries bilaterally may result in syncope. Now we do the supraclavicular group, and for the scalene nodes, we ask the patient to shrug. Open your mouth. Shrug for me, please. Yes, shrug a little bit more. Good. And we insert our index and middle finger into the insertion of the scalene muscles, feelings for the scalene nodes. Having done that, we are now going to do the axillary lymph nodes, and there are different methods. The surgeons will in fact teach you how to test for axillary adenopathy. This is one method. Hold the hand, elevate it upwards using your palpating hand, your right hand. One palpates for the different groups. Here I'm palpating for the medial group, the apical group and central group, and the lateral group. I move on to this hand, and I'm now going to use my left hand as my palpating hand. Again, the medial group, and the motion is a mobile one. Apical and central group, and the lateral group. We're now going to check for the epitrochlear lymph nodes. And we can finish examination of the lymphatic system by examining for the femoral and inguinal lymph nodes. Tell the patients what you're doing, but be mindful of the privacy of the patient. It is appropriate for you to lift up the sheet at this point in time, lift up the underwear. I'm going to just feel down here, okay? And palpate one group at a time. And for the femoral, lift up and palpate. Lift up and palpate. Having examined the lymph nodes, although we can now do the popliteal lymph nodes by asking the patient to bend and palpate, bend and palpate. We're now going to go back to the neck, and we're going to examine the thyroid. The examination of the thyroid involves inspection first. The thyroid, if you recall, it consists of two lobes, a right lobe and a left lobe, and an isthmus, and the isthmus is just inferior to the cricoid cartilage. You look there and you ask the patient to swallow. Swallow for me, please. And you can see that the patient has an anterior mass in the neck which moves with swallowing. You ask the patient to stick the tongue out. Stick your tongue out for me now, to make sure that this is not a thyroglossal cyst. If it were, that mass would also move with protrusion of the tongue. The examination of the thyroid gland starts off with your examination of the trachea. The trachea is determined by putting your index finger and your ring finger on the ends of the clavicle. Your middle finger should then fall directly on the trachea. Directly on the trachea. And you then check the position of the trachea between the ends of the clavicle on the right and on the left to see if the trachea is deviated. The trachea is not deviated in this patient. The rest of the examination of the thyroid is a posterior examination. We ask the patient to sit up, the neck is slightly extended, and we palpate using our index and middle finger. We push the thyroid over on the left lobe, and we use the middle and index finger to palpate the right lobe. As per all lumps, we're interested in size, shape, surface, tenderness or not, consistency, mobility, and of course size of each lobe of the thyroid. Are you comfortable? Having examined the right lobe, we then put the fingers across and now examine the isthmus. Having examined the isthmus, we're now going to push the right lobe across and now examine the left lobe. Again, size, surface, shape, consistency, tenderness or not. And during this test, we can ask the patient to swallow. Swallow for me, please, to determine mobility, and it also helps us to measure each lobe of the thyroid gland. We are also interested in whether we can get below the thyroid gland to rule out retrosternal goiters. At the same time, we are assessing this patient for a thrill, which the patient does not have at this time. Having completed the examination, we are now going to auscultate for any bruise. The presence of a bruit usually implies increased blood flow to the thyroid gland, as is seen in cases of hyperthyroidism. Also, this can be noted in patients who are on antithyroid drug therapy. We're going to ask the patient to take a deep breath in. Take a deep breath in for me. Take a deep breath in. Hold it, and then we auscultate. Auscultating each lobe. Complete the examination of the thyroid by checking the percussion note. We start at the angle of Louis and percuss upwards. Any change in the percussion note from resonant to dull would imply the presence of a retrosternal goiter. Lie down for me. We are now going to examine the patient's breast. In a male, of course, what we are interested in is whether there is extra breast tissue, and this is called gynecomastia, in which case you see a mass below the areola. You hold one portion of the breast and you palpate around. Hold, palpate around to determine the size. Squeeze up the tissue and measure the size. Squeeze up the tissue and measure the size. Squeeze up the tissue, measure the size. Complete your examination by checking for whether there is any liquid that can be expressed from the nipple. Any liquid that can be expressed from the nipple. Gynecomastia is a relatively common finding in children in puberty, as well as in elderly men. In other males, one may have to try to find the causes for this, such as hypogonadism. The examination of the skin is also important, and that simply involves looking at this patient. We can see if there is any skin rash, whether there are any hyperpigmentation, or, as can be seen in patients who have vitamin B12, for instance, whether there is any hyperpigmentation, such as in vitiligo, which is an autoimmune disorder, and whether there are any obvious skin rashes. And you'll learn some more about how to examine the skin when you do your clerkship in dermatology. We're now going to examine the pulse. Very quickly, for the pulse rate, the formal examination of the pulse in terms of volume, in terms of character, will be done when you are taught your examination of the cardiovascular system. Your examination of the hands can be very, very fruitful in that you may pick up many disorders based on your examination of the hands. Just simply by looking at the fingers, does the patient have a large hand, as you may see in acromegaly? Does the patient have spindling of the fingers, as you may see in persons who have systemic lupus erythematosus? Are there any deformities of the fingers, as can be seen in patients who have rheumatoid arthritis with ulnar deviation, for instance, or swan neck deformity or Boutonniere's deformity? Are there any nodules on the finger, as may be seen in persons who have osteoarthrosis with Heberden's nodules? And of course, we are looking at the nails. Are the nails healthy in terms of the shape, or does the patient have leukonychia, white nails, which is seen in hyperalbuminemia, or koilonychia, which is spooning of the nails, which is seen in chronic iron deficiency? We are also checking to see if there are any pitching of the nails, which you can see in psoriasis as well. Then we have a look at whether the patient has clubbing. Simply elevate the hand, look at the angle between the nail fold and the nail bed. If that angle is obliterated, that could be one of the earlier signs of clubbing. We then turn our bodies and choose one of the nail, the middle finger is appropriate, support it on our thumb, and then use our index finger, meet in the middle at the nail fold, and see if there's the increased fluctuance. This is one of the earliest signs of clubbing. Clubbing, of course, may be seen in patients who have cirrhosis, cyanotic heart disease, bacterial endocarditis, inflammatory bowel disease, any other disorders such as carcinoma of the lung, as well as empyema and other bronchiectasis. Having checked for clubbing, we're also going to be checking for splinter hemorrhages. Splinter hemorrhage is one of the vasculitic signs of bacterial endocarditis. We're going to also check for Dupuytren's contracture, which is a nodule that is palpated just below the ring finger and is a sign of, maybe a sign of chronic liver disease. Also, you can check for Osler's nodes and Janeway lesions, which are also seen in bacterial endocarditis. The state of the palms, whether the palms are warm and moist, which you can see in thyrotoxicosis, is also important. Whether there is a yellowness of the palms, which should be consistent with beta-carotenemia, is also important. Whether there's palmar erythema, and it is appropriate at this time to compare your palms with the patient's, assuming that your palms are normal. And palmar erythema is seen in thyrotoxicosis as well as in pregnancy. You conclude your general examination by checking for edema. And this is checked in this manner. At the foot of the bed, using your thumb, using the medial aspect of just above the ankle, firm pressure is applied. One then removes one's thumb and look to see if there's any pitching. If there's pitching, this is called pitching edema, and you need to find how severe it is by finding when the pitching edema stops, and this patient has mild pitching edema, and we keep on going up until we no longer can cause pitching. So he has pitching edema up to here. We can then also conclude by looking at the nails, looking for clubbing of the nails again, using the same method I had demonstrated to you previously. This concludes examination of the general examination system. So, how do we present our findings? We have a formal system for presentation. This is a young male lying propped up in bed in no obvious cardiopulmonary distress. The patient has bilateral proptosis, and the patient is not ill looking. On examination, the mucous membranes were pink and moist, and the patient was anicteric. There was no central cyanosis nor peripheral cyanosis. Further examination of the lymphatic system revealed the presence of non-significant lymphadenopathy, in that the lymph nodes were small, they were shotty, they were palpable, they were mobile, and they were non-tender. The lymphadenopathy was generalized and involved the cervical region as well as the inguinal and femoral region. Examination of the neck revealed a swelling in the anterior aspect of the neck, which moved with swelling. It was non-painful, it was diffusely enlarged, it was mobile, the inferior border could be felt. The left lobe measured a half of an inch by a quarter of an inch, the right lobe a half of an inch by half of an inch, and the isthmus was a quarter of an inch in the AP diameter. There was no bruit and there was no thrill. Examination of the nipples or the breast revealed the absence of gynecomastia or the absence of any substances being expressed from the nipple. The skin was essentially normal. There was some degree of mild diffuse hyperpigmentation, and the skin was relatively smooth and hairless. Examination of the hands revealed the absence of clubbing or any Janeway lesions, Osler's nodes, Dupuytren's contracture. The pulse rate was 80 beats per minute. The patient had mild pitting edema to just above the ankle.